Okay, I've got 7 o'clock in the UK here, which is a lovely sunny evening in the UK for once, which is amazing. So, thank you very much for everyone joining us tonight from all sorts of different places and asynchronously as well. I know a lot of people will watch this back. We've got a really good talk tonight on by Fabio, who's part of the cardiology team here at VET.CT.
Hello, everyone.
And it's on heart failure, cracking the diagnosis and management as well. So just before that, I want to introduce the specialist case advice team and service at VET.CT. So Fabio, if you can just move the slide on, that'd be amazing. Great. My name's Richard Artingstall, by the way, and I'm Director of Teleconsulting at VET.CT. And really, what I want to talk about is VET.CT in itself, but also the team that we're in, which is Specialist Case Advice. And VET.CT, I'm sure you know, you've subscribed to this and you're very aware of our services, but we are a global team of over 200 specialists providing exceptional radiology as our primary function, consulting, so case advice through a team of specialists in lots of different disciplines. We've got around about 50 specialists in 11 different disciplines, and we work in a very collaborative, multidisciplinary way. And then we've got education services as well, where we provide training to students and residents at different universities and specialist centres as well around the world. So it's the written specialist case advice that we're talking about today and introducing the team. We've got a series of webinars that have happened throughout last year, and we've got a few of them happening this year as well. So they should be happening every few weeks. So please do look out for that. Any information's on the QR code there. And what do we do? Well, really, we provide specialist written advice, case advice within 12 to 24 hours. In the UK and Europe, we also have a live availability to speak to orthopedics, neurology, internal medicine, or oncology. And really, you get support from friendly specialists to treat cases in-house or to make decisions on their pathway into secondary sort of care. And what we find is that the support that we give has massive effects throughout the veterinary teams, lots of different ways. But the one that sort of affects most, and I was a primary vet as well, is just reducing that stress that you can feel with case management. So we're essentially a multidisciplinary team on your shoulder with clear and detailed next steps. When we talk to our clients who are vets about their clients who are pet owners, the pet owners are delighted to stay with the vet that they know and trust, but also to have that specialist input as well. We provide really fast turnaround times for written advice. And one of the unique things about us is we feel that this is a conversation and a collaboration. So we offer unlimited follow-ups on cases. We start to discuss and become part of that case management as well. And the way you access us is you can pay for reports and interactions as and when, or we provide subscriptions as well. So if you want any of that information, have a look at the QR code or do get in contact with us or contact with myself, and my email will come up. Next slide, please, Fabio. So just a bit of housekeeping today. This will be recorded, so anybody who's registered will get a recording. The microphones will be turned off throughout. So, and then if you've got any questions, pop them in the chat, and I'll be reading the questions out afterwards for Fabio to discuss, and we can interact through the chat function as well. So just be aware of that. Next slide, if you can. Great. So yeah, great. To introduce Fabio, like we said, he's one of our cardiologists, fantastic cardiologist, well renowned throughout the world. Talking today about heart failure and cracking the code of diagnosis and management. So Fabio, over to you.
Thank you, Richard. Thank you very much. Thank you, everyone, for being here today. I hope you will find this webinar useful. It's a particularly important topic. Obviously, heart failure is one of the main emergency and clinical science that we deal with in terms of in regard to cardiology. So I hope is going to be useful. So to start with, I just want to clarify the definition of heart failure, which is in here in the consensus of mitral valve disease is reported as the clinical signs caused by heart dysfunction. And this is very, very important. It seems very simple and very basic, but it's actually very important because heart failure means that there is some clinical signs. It's a syndrome of related to a heart disease. And this basically tells us that to have heart failure, you need to have evidence of heart disease. So evidence of a heart disease that is severe enough to cause clinical signs as a consequence of that heart disease. So it's not just about having heart disease, but is having symptoms related to that disease. And the reason why this is important and the diagnosis is extremely important is that we want to be completely sure about this, because diagnosing heart failure is a lifelong commitment for our patient. Once you diagnose heart failure, it means the heart is failing on its own to deliver the bloods and nutritions the system needs to. So what we need to do is give him medication for the rest of his life. So reaching a diagnosis is obviously essential. We don't want to overdiagnose, but also we don't want to underdiagnose things. How do we do a diagnosis of heart failure? There is different ways we can diagnose it. Let's say we can add our different factors to our suspicion of heart failure based on clinical diagnosis, laboratory diagnosis, radiographic diagnosis, and echocardiographic diagnosis. Nevertheless, I want to be certain that you guys are aware that at the stage, still at the moment, at present, radiography is still the gold standard diagnosis for heart failure. If you think about what it is, heart failure, mainly, we're talking here mainly about left-sided heart failure, is a heart disease of the left side that is causing clinical signs related to that. And the clinical signs are mainly going to be tachypnea and dyspnea, which we will see in a second, but they are mainly related to what? To pulmonary edema. So there is a big left side, a big left atrium, increased pressure in the left atrium, and this is going to result in development of pulmonary edema. So the pulmonary edema is technically in the lungs, isn't it? Is in the pulmonary interstitium, is not something that is just in the heart. So what we need to do is looking at the lungs, which is not something that we do with the echocardiography, it's not something that we do with the lab diagnosis, but we do it with radiography, because with the radiographic assessment, then it's when we look at the pulmonary space and lung space and other things that we will see later. So the clinical diagnosis is based on few simple but very important things. First of all, signalement. Obviously, is more likely than a cavity, an adult cavity is in heart failure compared with a breed that perhaps is more likely to develop boas. It's not always the case, but signalement can definitely help. And I say cavity, I mean also small breed dogs in general that are likely to develop mitral valve disease and congestive heart failure as a consequence of that. But also Doberman are likely to develop DCM and potentially heart failure secondary to that. So signalement definitely can help. The clinical history obviously is fundamental. As I said before, heart failure means clinical signs related to heart disease. So the client is going to report the presence of some clinical signs. These clinical signs need to be related to the heart disease. So if they report lameness in a dog, obviously in a cat it could be, but in a dog, that's not a clinical signs that are related to congestive heart failure. And whereas if they report all the clinical signs that we will see in a second in a dog that has a predisposition in mitral valve disease or DCM or HCM, that might be more likely to be in congestive heart failure. So all these little things can be put all together to confirm, to support the diagnosis of congestive heart failure. I said confirm, but that's wrong. Obviously, to confirm the diagnosis of congestive heart failure, as I mentioned before, you will need an X-ray. Physical examination, there is few things that we can see in physical examination that might support, once again, my suspicion of congestive heart failure, and we will see that soon. So the clinical signs, again, those are fundamental because we need clinical signs related to the heart disease in order to confirm the presence of heart failure. And the clinical signs are, if you're talking about left-sided heart failure, is mainly dyspnea and tachypnea. And this has to be a persistent clinical signs. If the client reports the presence of dyspnea, mainly at night, and then in the morning is absolutely fine, if we think of what we said before about the development of pulmonary edema, so accumulation of fluid inside the lung interstitium, it's impossible to believe that this is present at night and then in the morning it's gone, even without giving any medication. If it improves after the medication, which is mainly going to be diuretic, obviously yes, but that's why the dyspnea and tachypnea associated with the heart failure is not an intermittent episode. It's a persistent clinical signs that is always there and potentially worsen with time. All the potential clinical signs are abdominal distension, mainly if we're talking, sometimes with left side disease as well, if it's very advanced, but mainly in right, sorry about that, mainly with right-sided heart failure, we will see development of abdominal distension, so ascites. Lethargy is another thing that we see both in left and right-sided heart failure. Anorexia, hyporexia, and cachexia, I would say those are mainly present with the right side, but with very advanced left-sided heart disease that result in left-sided heart failure, you might also see this. Syncope, it could be another clinical sign associated with left-sided congestive heart failure. Arrhythmias, this is related to the fact that there is an underlying disease that is causing potential changes of the heart, and so it might result also in arrhythmias. And then I left cough here down on the very bottom of the list because it's a bit of, there's some discussion about cough. I would not consider, what I want you to know from this presentation, one of the things, is that I would not consider cough as the main sign of congestive heart failure. Is actually, to me, is unlikely the cough is a sign of congestive heart failure. And I'll explain you why. There is a very lovely paper that was done by two of my colleagues, and they explain exactly why. So a cardiac cough is a cough that is associated with a cardiac disease, obviously, but not necessarily with pulmonary edema, so not necessarily with congestive heart failure. As we said before, congestive heart failure means, and we're talking about left side again, means development of pulmonary edema. So there is a problem that's been happening at the level of the alveoli initially, and then potential the interstitium, the lung interstitium. As you can see in this graph here, in this picture here on the right, the receptors that stimulates the cough, so the cough receptors in the airways are mainly present at the level of the larynx, trachea, bronchi, and sometimes more just the main bronchi, but not at the level of the alveoli, not at the level of the interstitium, not at the level of the bronchioles. So that's why if you develop pulmonary edema at the level of the alveoli, there is no reason why that should trigger cough receptors. And that's why it doesn't cause cough. Obviously, if you have a very enlarged left atrium or very enlarged heart and associated airway disease, which are two very common things that happen in small breed dogs, then potentially the cardiomegaly might contribute to that compression on top of bronchomalacia present at the level of the airways that will contribute to the cough, but is not the main cause of the cough. So it might be a concurrent clinical sign. So you might have cough because perhaps that's usually a persistent clinical sign that lasts a very long time. But that doesn't mean that it's in congestive heart failure. And the classic example is a little Jack Russell that comes in for a check. The client is concerned about the cough and you hear a murmur. That doesn't tell you that there is heart failure, because that clinical signs, as we said before, was in the bottom of my list. And I actually think it shouldn't really be there, or should be very, very little there. What we will consider in that case is that perhaps there is a tracheobronchomalacia, so there is like bronchial collapse or obstruction of the tracheal collapse, and mitral valve disease, and potentially the mitral valve disease is enough to cause a big left atrium that result in compression of the airways, which as a result will cause an even worse cough, but the cough is not caused by pulmonary edema, so that dog basically doesn't need furosemide. So only if the cough is present with severe dyspnea and tachypnea, then I could consider that as a potential clinical signs associated with congestive heart failure. But in the absence of these main clinical signs for congestive heart failure, I will consider probably associated with the primary respiratory disease. One thing that is extremely easy to evaluate, and again, if we consider the main clinical signs of left-sided heart failure, dyspnea and tachypnea, it's very easy to understand why we do that, is assessing the respiratory rate. It's been proven that a dog that has a controlled heart failure with medication should have a respiratory rate below 35 respirators per minute. So it's very easy to ask the client to control this at home, because obviously in the hospital will be affected by stress. We ask every time, every client that we have, every patient that we have, we always ask this question. At whatever stage the disease is, we always want to know, want to be sure the client knows what to look for. And the main thing we need them to look for is the respiratory rate. If the respiratory rate starts to increase persistently, we obviously need to be concerned that perhaps there is an early progression to heart failure. So we will need to investigate that and confirm that. Even before, so let's say the client has noticed a respiratory, an increase in the respiratory rate. Even before we do any particularly invasive test, we could consider adding more factors into my suspicion of congestive heart failure. And this can be added just by doing a clinical examination. The respiratory rate and effort, we say, is going to be increased. The membrane mucous color might be pale. Sometimes it can start to be cyanotic if there is an advanced respiratory disease as well, but usually they are pale with a prolonged CRT. The pulse quality might be reduced. The heart rate is usually faster, because one thing that we need to remember is that even before the congestive heart failure develops, you have activation of sympathetic tone. So the sympathetic tone is going to cause vasoconstriction, but also increase respiratory rate. So as a consequence, you may have an increased CRT, you may have an increased heart rate. Obviously, you have a murmur most of the time, especially in dogs. It's not the same in cats, I'm afraid, but we will see that later. But usually also have a murmur. And in some cases, you can hear an increased lung sound, an increased bronchoversicular sound. It's not always present, but it might be there. And if it's there, also remember that a crackling sound or an increased lung sound might be caused also by something else. So always keep that in mind. If you're brave enough to check the temperature in a cat, we also know that if a cat presents with, and this is a very easy and simple test that we can do, if a cat presents with respiratory distress, and we're not sure whether it is primary respiratory, an asthmatic cat, for example, or is due to congestive heart failure, if we check the body temperature, the rectal temperature, and this is below 37.5 Celsius, is more likely that that cat is in heart failure rather than have a primary respiratory disease. And this is usually, it is very true. There is a really good sensitivity and specificity of this test. And again, it's a very easy thing to do. And it will be, I would not make the diagnosis just based on this test, but it will definitely help me understanding whether my suspicion of heart failure is strong or not. Laboratory diagnosis is not that accurate, obviously, but again, we might be able to use it as in addition to everything else that we've done so far. First of all, if a fusion analysis, we can do that. In an emergency setting, might not be that useful, but the thing that might be important is, first of all, if there is pleural effusion, for example, in a cat, most of the time they require drainage. So at that point, is it therapeutic and also diagnostic? You might see an hemorrhagic effusion, and then at that point, your suspicion of congestive heart failure will start to get lower in the differential. Whereas if it's a transudate, a clear transudate, then a modified transudate, obviously the diagnosis or the suspicion of congestive heart failure might still be quite high in the list. In regards of doing some cardiac biomarkers, it is still possible. They might be useful to do, but I guess at that point, and this is true for any time that we perform any test, we need to ask ourselves why we're doing this test. As you might know, cardiac troponin I is a marker of myocardial damage. And you might have myocardial damage, you might have ischemia, for example, in a cat with HCM, sometimes they do, but you might not have congestive heart failure. So that doesn't really help much. Whereas the BNP, for example, is present in vesicles in the myocardium, but the trigger that makes the release the BNP in the circulation is actually stretching of the myocardium. So it means that the heart is getting bigger. And that could potentially support that there is such an advanced heart disease, potentially with a big left atrium, that is essential for development of left-sided heart failure. So that might be more useful than troponin. Nevertheless, it's not specific. It will tell you that there is a big left atrium, but it might not tell you that definitely there is congestive heart failure. However, you can use a point of care evaluation of BNP in an emergency settings, and this seems to have a relatively good sensitivity and potentially a decent specificity as well in the diagnosis of congestive heart failure. So again, once again, if you have a cat with respiratory distress and you're not certain whether it's primary respiratory or primary cardiac, by assessing the BNP, even just taken by the pleural effusion, so by the sample of the pleural effusion, it might give you really good indication whether heart disease is more likely versus respiratory disease. And this is quite important. It's quite a nice test, isn't it? Because if you think, as we said before, most of the time they require pleural effusion to be drained anyway. So at that point, you have drained the pleural effusion. Hopefully, you're making your patient breathing better. You can see the sample, whether it's hemorrhagic, the transudate, and so on. And also, you can run a BNP on that test. Obviously, it needs to be one of these points of care, because if you need to send it away for analysis, that might not be that useful in an emergency setting. As I mentioned before, though, the main, the gold standard, the diagnostic test for congestive heart failure will still be the radiographs, the thoracic radiographs. And as you can see in this picture, obviously there is a lot of structure. Main one for us would be the cardiac silhouette. Sorry, we don't want, but we need to have cardiomegaly. We need to have congestion of the pulmonary vein. We need to have infiltration of the interstitial or alveolar pattern or mixed pattern at the level of the lung interstitium, which is not the case in this nice radiographs, which is a completely normal dog. But I just want to show you where to look for the pulmonary vein, which is this one in blue, whereas the pulmonary artery is in red. And we usually try to assess them together, whether they look similar in size or not. In this case, you can see the pulmonary vein is always ventral in lateral and central in DV, and the pulmonary artery is usually dorsal. Okay, and the same thing in DV. We always assess the pulmonary vein size as well, because we want to know whether there is a congestion of the pulmonary vein because of what we said before. To be in congestive heart failure, you need to have a big left side, big pressure that is then transmitted to the pulmonary vein. So the pulmonary vein will get bigger, and then eventually you develop pulmonary edema. So those are all things that we want to look into a radiograph, a thoracic radiograph, to confirm the presence of heart failure together with presence of interstitial factor. Before we pass to another radiographs, I just want to clarify the presence, the position, sorry, the location of left atrium in the DV, because it's quite important. As you can see here, if we use the analogy of the clock, you can kind of highlight the location of different structure in the heart. But in this one, with the clock analogy, we can't find the left atrium, because the left atrium is actually in the middle of this, well, kind of in the middle of the chest, not in the middle of the cardiac silhouette, but is positioned there, exactly in between the two bronchi. So you can see how the trachea goes down. In this case, it's a bit wonky. I don't know if you can see my mouse, but it's just here on the right side. And then it gets to the top of the red circle, and it goes down like this. Okay, this is a classic morphology of the bronchi. But if I have something in between the bronchi that is getting bigger and bigger, the first thing that is going to happen is that those bronchi will not have a reverse V shape anymore, but will start to get rounded. So they kind of assume, I'm sorry, I'll show you now, this cowboy leg appearance. So they get very rounded around the left atrium. And this can be something, again, that we can use to confirm the diagnosis of congestive heart failure, or at least to confirm the presence of cardiomegaly. In fact, in this dog, for example, this is the right lateral. You can see there is significant cardiomegaly there. Let me see if I can use my laser pointer. So significant cardiomegaly, I guess we all agree with that. This dorsal, cododorsal portion of the heart is the left atrium. If you remember the anatomy, obviously that's the area where the left atrium should be. But there is no vein congestion. So there is significant cardiomegaly, but no vein congestion. The interstitium appears to be normal as well. But this dog is coughing a lot. But obviously, can you see this little black line here? I should say radiopaque line here. That's a bronchi that's been squashed by the left atrium. So this is very likely a dog that has mitral valve disease, very advanced mitral valve disease, and is coughing, but is not in heart failure. He's only coughing because that little bronchi is significantly compressed. If that bronchi, though, was a rigid structure, even with an increased cardiomegaly, that structure will just move up. Whereas because there is a problem with the airways, and they are not rigid anymore, they're just floppy, as soon as the heart gets bigger, it will squash these airways and contribute to the cough. But there is no evidence of heart failure in this X-ray, and this is confirmed here as well. You can see in this particular case is obviously a very obvious left atrium enlargement, to the point that the left auricle is also quite big. There is a bulge in between 2 and 3 o'clock, and then the cowboy leg appearance down here, but not evidence of congestive heart failure. Sorry, I thought there was another X-ray here, which I think is here. Sorry, let me just go there. Here, this is what I wanted to show now. Here also there is congestive heart failure. Sorry, there is cardiomegaly. But on top of that, there is a cardiomegaly that is so big, but we can't really see the edges of the heart, the cardiac silhouette. Also, there is congestion of the pulmonary vein. You can definitely see here. You can see them here as well, although here is mainly a alveolar bronchogram. So basically is full of fluid everywhere, but not the bronchi. And same thing here. You can see that there is an interstitial alveolar pattern with some air bronchogram. So this is telling you that there is cardiomegaly. You can see the left atrium here is big with this cowboy leg appearance here. And there is some interstitial pattern with pulmonary vein congestion. This is definitely confirming the presence of congestive heart failure. Okay. This X-ray here was just to show you that if you're in doubt, if you're not sure whether there is cardiomegaly or not, you can obviously use VHS, so vertebral heart score. And there is a range that works for every single breed. But then nowadays we know that the breeds are so different in terms of chest morphology, and we're moving on to breed-specific ranges. So it will be better if you can find the ranges for each breed when you're assessing them. In cats, the radiographs are not always that easy to recognize. I'm afraid cats always like to make things a bit more complicated. But once again here, if you have a VHS on radiographs that is more than 9.3 in a cat, and we measure the same way as we measure for dogs, in a cat that is presented with respiratory distress, that makes it more strongly associated with cardiac disease rather than a primary respiratory disease. So all these little things that we can put all together and try to support our diagnosis of congestive heart failure. Very briefly, echocardio is not the gold standard for congestive heart failure diagnosis. What we can do with echocardio, if you do an advanced Doppler echocardiography from right and left-sided, and you can assess the filling pressure of the heart, mainly of the left side, left heart, you measure the size of the heart and things like that, then you might increase your suspicion of congestive heart failure. But again, it's not a final, it doesn't give you a final diagnosis. What you need to see to have on an echocardio, if you are trying to confirm the presence of the heart failure, is the presence of an enlarged left atrium. If we're talking about left-sided heart failure, so you cannot have congestive heart failure without an enlarged left atrium. There is only one exception, I should say, which is a chordal rupture in case of mitral valve disease, where the rupture is very quick, the left atrium doesn't have time to get big, but the pressure goes very, very high, and you can develop congestive heart failure. But other than that, most of the time, you need to have a big left atrium to support congestive heart failure. Same thing for the right side. I don't know if you recognize this picture, but this is a right parasternal short axis view at the level of the base. So you have the aorta in the middle here, and this is the left atrium, which is a big auricle as well. And this is a right parasternal long axis view. These are supposed to be video, but now I don't know why. Oh yeah. So this is a right parasternal long axis view with the left atrium down the bottom here, and then the right atrium that looks very, very enlarged. So if you have a dog with ascites and you have this presentation in your echocardio, then you can support the presence of right-sided heart failure. B lines, just very briefly, because obviously they can help. B lines, though, I don't know if for the ones that you don't know. So this is a normal appearance of lung on ultrasound with these horizontal lines. Whereas if you start to have this, sorry, in picture A, let me see if I can put back this. In picture B, you can see these lines, perpendicular line, and the more they are, the more likely is that there is a significant problem, but they're not specific for heart failure. They can be there for any type of pulmonary infiltration. But we sometimes use it, again, to support that presence of congestive heart failure together with other things. So they might be there in congestive heart failure, or they might be there even without congestive heart failure. So it's not that specific or sensitive. Now, let's move on the acute management. Obviously, I want to discuss acute and chronic management, but I'm conscious of time, and we're just going to focus on acute management today. It's easy to say and to remember that they are struggling to breathe most of the time. We're talking about left-sided heart failure. So the main thing that they need when they come as an emergency is supplementation of oxygen. Regardless of the way you do that, you want to make sure that you supplement that oxygen that they're struggling with. Another thing that we might sometimes do, especially in cats, I have to say, if they are particularly anxious, is using a sedation. Most of the time we use butorphanol on his own. I put here 0.1 mg per kilo, but we can go up to 0.4 mg per kilo. So we do use higher dose than that. And this is easy to use as well because you can give it intramuscularly. It usually gives you the right effect that you need to calm them down in order to stop the vicious cycle of a cat that cannot breathe, then it gets stressed, and then it can breathe even worse, it breathes even worse. So what we do is try to stop this cycle of dyspnea. If there is any fluid, which should be, if we're talking about congestive failure, we need to remove the fluid. So obviously, if it is pulmonary edema, we need to give diuretics to remove the fluid. If it's an effusion, so ascites or pleural effusion or pericardial effusion in some cases, we might need to drain. It is true that we very rarely drain ascites because most of the time that's not contributing to the major presentation. So it's not contributing to the breathing, to the respiratory distress. But if we think that the ascite is severe enough to cause like a distension of the abdomen with compression of the diaphragm, contributing to the respiratory distress, then at that point we might need to remove it. Otherwise, what we do is we treat the heart failure, and once we make the heart working better, that should help draining the ascites. Another thing that we can do is improving the hemodynamic function, which we will not do with furosemide. Furosemide will only remove the fluid, But if we use positive inotropes, then the most likely one, we might have the hemodynamic function, so we might have the heart moving the bloods away. And one thing that, again, another thing I want you guys to take as a take-home message is even if you might have cases with kidney disease, perhaps at that point, obviously it's going to be very difficult to control. I agree with that. But if you need fluid therapy, it's starting to get a bit more challenging case. Basically, because you need to consider this patient as if it was a glass full of water. If you give something to remove the water, but then replace the water with fluid therapy, we're not going anywhere. So I can understand the condition where you have cardiorenal syndrome. You want to give some fluid to try to help the kidneys, but I'm afraid those are very complicated cases. They are sometimes very challenging to deal with. The mainstay in treatment of congestive failure, regardless of all the advancement that we have made so far in veterinary medicine, is still furosemide. We still want to remove that fluid. We usually start around 2 mg per kilo, and then we do 1 mg per kilo every hour or two, depending on the condition, and then we treat based on response. You can also consider CRI. Is usually easier in larger dogs, but you can do it. You can do CRI as well. It just makes it a bit easier the administration, at least at the very beginning. And always remember to monitor electrolytes and renal parameters because furosemide can cause changes at that point. We discussed the improvement in the hemodynamic using inotropes, positive inotropes. Pimobendan is probably going to be the most likely one. There is an injectable version. It's extremely expensive here in UK, but we use it when we need it. But I have to say that most of the time we are still okay with an oral pimobendan because that has a relatively fast effect. Dobutamine is something that we consider sometimes. To be fair, I probably use it once or twice. The main risk with dobutamine is that it can cause arrhythmias as well. In regard to pimobendan, there is one thing that we need to be aware, and is the conditioning in which where we are treating a cat with congestive failure. If we're treating a cat with congestive failure and we believe he's got hypertrophic cardiomyopathy, then we need to be aware whether this is an obstructive form, so the HOCM, or just an HCM. If there is an obstructive form, so the form where you have, as you can see in this video here, you have an obstruction at the level of the LVOT, which is somewhere here. Can you see there is an obstruction just there? If you have this dynamic obstruction and you use pimobendan, you risk to increase the contractility and potentially make that obstruction even worse. So I'm afraid in cats, we need to be aware whether there is an obstruction or not before we consider pimobendan. Also, especially in the short term, in the acute term, the acute management. Another possible strategy that you can add on top of the furosemide and the positive inotropes is the use of vasodilator. It's a bit controversial and sometimes can be quite dangerous because what we're doing is reducing the blood pressure potentially even more. But the aim basically is to create a pool somewhere else, away from the lungs, where all this fluid can be moved on. So what we do is we can give vasodilators. So most of the time we give mixed vasodilators, so arterial and venous dilator, such as sodium nitroprusside or nitroglycerin. And what they do is, as I say, they create a pool where the blood can move away from the lungs. Again, the strategy is extremely interesting and sometimes works really, really well, especially in those cases they are struggling to respond to diuretics only. But it could potentially drop the blood pressure quite drastically. So we need to be aware of that and try to understand when is the case. I would not do it as a fast approach, but if the patient is struggling to respond, then I will definitely use this as well. If there is anything else on top of the congestive failure, so arrhythmias or pleural effusion or airway disease, I will need to control those as well, on top of everything, to try to control the heart failure as much as possible. And just to summarize, sorry if I took a bit longer than I expected, in presence of congestive heart failure, first of all, try to add all these clinical signs and clinical presentation and physical examination presentation to your suspicion of congestive heart failure. We have a lot of tests that we can do to try to support that, but the main test will remain thoracic radiographs. Once you are certain that this is congestive heart failure, in an acute setting, you need to make sure you supplement oxygen. That has to be your first thing to do. If you need, you can sedate to break the vicious circle of stress and respiratory distress. Remove any excessive fluid, so furosemide, if we're talking about left-sided heart failure and pulmonary edema, but also pleural effusion and ascites can be drained if they need to be done, if that needs to be done. Using positive inotropes such as pimobendan to try to improve the hemodynamic function of the heart and help removing all this fluid. And please don't use fluid therapy in a case of acute congestive heart failure, because that will just make the control of heart failure extremely challenging. So hopefully it was useful, and I will be very happy to take any question if you have any. Thank you very much.
Yeah, that's great. Thank you, Fabio. Really practical. I think I took a lot from that, just the solid sort of practical basics all put into place, and then actually it's such a logical approach. So thank you very much. Yeah, there's a couple of questions. If anybody's got any questions to pop in the Q&A, then do take advantage of that. I think I found that I never quite knew about that 37.5 degree temperature as a sort of screen, I presume, rather than a diagnostic test. But it's a really practical way of doing it. And I've been presented in lots of situations like that. I think Christina said that she just lost the details of that. And could you just go over that? So she lost the details of discussing the temperature in cats.
Yeah, there is a very nice paper, and there is the sequel of that paper actually is coming out soon. It's called the VET.CT, and they found out that one of the things that makes the diagnosis of heart failure easier in cat is actually assessment of the rectal temperature, and they found that if the rectal temperature is below 37.5 in a cat that is presenting with respiratory distress, is much more likely to be in heart failure than having a respiratory distress because of primary respiratory disease. And if you think that makes sense, and it's always nice when it makes sense with physiology or pathophysiology, because as we mentioned before, one thing that happens in congestive failure is activation of sympathetic tone. So increase heart rate, but also vasoconstriction. So you might end up with a peripheral perfusion that is reduced, and that's why you might have a lower temperature than if it was, for example, a respiratory distress because of primary pulmonary disease. So yeah, that's easy enough if you're brave enough to check the temperature of the cat. But if you can do that, and most of the time you can do in these cases because they are unwell, so they are quite amenable for that test. Yeah.
That's great. And then Elena has asked a couple of questions. One of them was around proBNP. So what's your opinion on using proBNP as monitoring tool for dogs with a heart murmur? If you have a dog with a grade 3 to 5 or 6 murmur, that you do a proBNP and it's normal, but the next year the proBNP is raised, would you say that it's reasonable to start the dog on pimobendan with no x-rays?
The simple question is a really good point. A simple question will be no. The simple answer, sorry, will be no. Mainly because, again, the BNP is telling you that there is a stretching of the myocardium. It's starting to get bigger. But do we know how big? And is it just the left atrium, or is it the left atrium and the left ventricle? Because technically, for you to start pimobendan, we're talking about mitral valve disease in this case, I guess. But for you to start pimobendan in a case of mitral valve disease, you need to have a few echocardiographic measurements, the presence of a murmur, and so on. If we don't, with the BMP, we will not know whether we are reaching that stage or not. I think there is going to be some study already that trying to investigate at what time we can start BMP. I think it's just going to be very difficult though, because patient will raise BMP in a different way. We know that the even the reference ranges now is different between breeds. So it's going to be very difficult to be very accurate on when to start pimobendan just based on BMP, because it's not as specific as it could be an X-ray or an echocardiogram, even better. So in this case, if you want to stage the disease, the echocardiogram is obviously better than the X-ray, but there are other ways how you can assess the left atrium size based on the X-ray. So you can do that. I just don't think that I don't think we're going to save a huge amount of money just by doing BMP. At that point, you can probably do an X-ray, even better if you do an echo. And also, you might start pimobendan too early and then end up and then you end up using a relatively expensive drug for a much longer time, and that amount of time and the amount of money could have been used towards an echo, which is going to give you a much more specific diagnosis. So the short answer is probably not yet. I will not use BMP to decide, only BMP to decide whether to use pimobendan or not.
And then the subsequent question was that if you did confirm cardiomegaly, would you start the dog on pimobendan?
If it's a specific cardiomegaly, so the ACVIM consensus on mitral valve disease gives you exactly what you need to have to confirm the stage B2 mitral valve disease, which is when we start pimobendan. And if I remember rightly, so you have a VHS, which I think is more than 10.7, and then the left atrium size, which is the VLAS, is called VLAS. It's a specific measurement. It's similar to the VHS that you can do just to measure the left atrium. And they say that if you can't do echocardio and you want to base the staging of mitral valve disease just on X-ray, you could use a VLS of more than 3. I think it's more than 3. I believe it's more than 3. It's on the ACVIM consensus. Then you can use that to support the diagnosis of stage B2 mitral valve disease and then start the pimobendan. But if the left atrium is not that big, then obviously it's a simple answer. We don't need to start pimobendan.
Great.
But yeah, X-ray could be, so I would probably say echocardio, the main way how to stage the mitral valve disease, X-ray is the second, BMP only after that, and not as accurate as any of these two.
Okay. Question from Elliot. What drugs do you use to sedate patients for radiographs if you suspect congestive heart failure?
So we use mainly butorphanol, and if just to relax, to calm them down. If it's not enough to actually just lay them out on the table to do an X-ray, then we top up with alfaxalone. And most of the time, I would say 99% of the time, this is enough. If it's not enough, sometimes we use midazolam as well, sometimes a low dose of ACP. But butorphanol and alfaxalone is the combo. So we use butorphanol between 0.2 and 0.4 mg per kilo, and alfaxalone to effect IV. And if it's not enough, as I say, perhaps we can top it up with either the alfaxalone or we add midazolam to the anesthetic plan, to the sedation plan.
Fantastic. Georgina has asked, to get chest x-rays, if your animal's in congestive heart failure, what agents would you use to anesthetize them? So I think similar question, but would you anesthetize a dog to get x-rays, or would you sedate?
Usually, so that's why we use alfaxalone, because alfaxalone lasts like 10 minutes, and that's all you need. You need much less than 10 minutes, to be fair, to take a thoracic x-ray to confirm heart failure. So I would only sedate them, to be completely honest with you. If you need to do general anesthesia for something else, I will probably wait for the congestive failure to be well controlled fast, and then consider anesthesia at that point. I would not sedate them. Also, because if you sedate them, you need to intubate. It takes a bit long. Everything takes a bit longer. You just need, if you need to do an X-ray, you need 10 minutes of sedation, and I don't think you need a general anesthesia for that. So yeah.
So Emma's asked, if you have a cat in acute congestive heart failure with an arrhythmia, would you prioritize stabling the congestive heart failure and then investigate the arrhythmia further?
Yes, absolutely. So again, the congestive failure is going to be the life-threatening condition, unless the arrhythmia is a ventricular tachycardia, which is unlikely, especially in a cat. Um, I would say always look at the congestive failure fast, also because that congestive failure is causing an increased sympathetic activation, which might contribute to the at least the um, not the trigger, but the I can't. It's too late for me to speak English now. For to maintain the ventricular arrhythmia, that sympathetic tone might be contributing to that. So if you improve the congestive failure, you might drop the sympathetic tone, and you might improve that arrhythmia. I'm not saying that you converted the arrhythmia, but instead of 200 beats per minute, you might go down to 180, and that might be enough to keep everything stable for a bit longer. Obviously, if, as I mentioned before, if there is atrial fibrillation or ventricular tachycardia on top of congestive failure, once you've got that nicely controlled, you need to address the arrhythmia as well, because they can contribute to each other. So the sympathetic tone might contribute to the arrhythmia, but if you don't control the arrhythmia in the long run, then you might not be able to control the congestive failure very well. Because one of the things that we need to remember is the heart rate is essential for the cardiac output. If we go to the extreme of the heart rate, so very fast or very low, we are going to reduce the cardiac output. And that's what we don't want to do in congestive failure. We want to keep an adequate cardiac output. So address the heart failure, I would say fast. So oxygen and furosemide as the main thing, and then investigate the arrhythmia and try to control that if you can.
Great. And how often do you find you have to treat arrhythmias in cats with advanced cardiomyopathy?
Very rarely.
Okay. And are you haltering cats before treating?
Before treating for arrhythmias, depends. So if it's an obvious arrhythmia, if it's an atrial fibrillation and is obvious on ECG, and it seems to be fast enough persistently, perhaps we can start the treatment even without doing a Holter. The Holter is essential most of the time, especially in dogs, to try to understand how severe it is or how persistent it is during the 24 hours. So obviously at that point it becomes an essential test. But if on the ECG I already have a diagnosis of ventricular tachycardia, let's say even persistent or even just frequent ventricular tachycardia, I don't need to do an Holter to know that that's quite dangerous. So I can start treatment even before doing the Holter. Also, doing a Holter in a cat is not that easy. What we now do is we just put the Holter and keep them in the hospital anyway. We don't send them home because we try a few times and it didn't work. So yeah, you need to consider that as well. I guess if they're in because they are in congestive failure and then you want to investigate the arrhythmia, that's a good time to put a Holter as long as they're stable enough to suffer with a jacket in the hospital. But yeah.
That's great. You may well have answered this next one to Elena, but just to confirm, so it was around the proBNP. So you use it as an adjunctive test when trying to diagnose heart failure.
All those tests that I mentioned, the temperature, obviously all the findings on the clinical examination, the clinical history, the signal, all these things have to work as a team all together to increase your suspicion of diagnosis. The only test that on its own can give you a diagnosis of congestive failure is thoracic radiographs. Everything else is just supportive of that. I'll give you an example. If I have a cavity with a loud murmur, it's got crackles, it's got B-lines on T-fast, I do a quick echo and he has a big left atrium, potentially some increased filling pressure. Obviously, I can check that. I don't know how confident you guys are with echocardiogram, but if you can't check the filling pressure, you already have all these features. There is crackles, there is B-lines, there is big left atrium, there is an evident mitral valve disease. Obviously, my suspicion of heart failure, if the dog is presented with the clinical signs that can be associated with that, so with severe tachypnea and dyspnea, it's very, very high. Potentially, I don't need to do an X-ray unless I'm not completely certain. So what sometimes I do, I start treatment for heart failure straight away. I'm not confirming heart failure. There is a very high suspicion of heart failure, but I can put all these things together and support why I'm starting treatment of congestive heart failure. If the congestive heart failure treatment works, then I have a confirmation as well. It's definitely working, it's definitely heart failure. But even after we've done a full echo and we've confirmed the presence of increased filling pressure, we have B lines and everything, sometimes we start the treatment, it doesn't work. So then the only thing else that we can do is to do an X-ray. And sometimes the X-ray says actually it's not in heart failure, it just has a very advanced heart disease. So please remember, the only way we can confirm it is thoracic radiographs, but all these other tests will support your diagnosis. It will make you more confident that the treatment that you are going to use is the right one.
Brilliant. Okay, this is great. So in patients with severe pulmonary edema, well, that's just jumping around, sorry. Where is it? Yeah, in patients with severe pulmonary edema, when would I have to start 4 mg per kg furosemide bolus? And would it be wise to start a low fluid rate infusion too?
Okay. So the first question about the 4 mg per kilo, there is no straightforward answer. Some people start 4 mg per kilo straight away. I usually start on 2 mg per kilo. But if I see that the patient in front of me is really struggling, I'm afraid there is no consensus on when, and I can't tell you which one I will. Perhaps if you give me the same case twice, once I will start on 4 mg per kilo and once I will start on 2 mg per kilo. I'm afraid there is no right straightforward answer there, but it depends on the severity. So starting on 4 mg per kilo is not wrong. Technically, what we used to say is that you shouldn't go over 12 mg per kilo in 24 hours of furosemide. Most of the time, again, 98%, 99% of the time, we don't go any close to 12 mg per kilo in 24 hours because we're quite aggressive in the first few hours and we usually reach a really good steady level of respiratory rate relatively soon. But if we don't, we keep going until we get to a normal or a lower respiratory rate or an adequate respiratory rate. So I'm afraid there is no straightforward answer for that. It depends on the severity of the presentation, how quickly you want to improve the clinical signs and things like that. I guess at that point, you will also need to consider, and this is something that we always do, we do a baseline biochemistry to make sure that there is no signs of kidney injury as well. Because if there is already some sign of azotemia, you might not want to start with 4 mg per kilo straight away. And the blood pressure as well. If the blood pressure is already pretty low, you don't want to be too aggressive and drop the blood pressure even more. So yeah, there is consideration that needs to be case specific regarding on the dose that you use. And in regard of the fluid, as I mentioned on the slide, no. I wouldn't give any fluid support. As I say, consider this dog or this cat as a glass with water. And if your aim is to remove that water from the glass, you give diuretics, but if you give fluid on top of it, you're not improving anything. You're just continuing with the same amount of volume. So yeah, I would not consider fluid in acute congestive heart failure.
Okay. We'll probably do another couple, I think. With atrial fibrillation in cats, are you using digoxin and diltiazem or just sole therapy?
Atrial fibrillation in cat is a bit different than, well, it's the same thing than in dogs, but the treatment might be a bit different. I personally, it's true that in dogs it's been proven that digoxin and diltiazem together prove a better rate control than if you use singularly. But I personally still start on diltiazem first, and if that's enough to control it, I'm happy with that. If it's not at a decent dose, like 3 mg per kilo TID, then I start digoxin as well. In cat is a bit different because cats sometimes might have other issue, like for example the SAM, the systolic anterior motion, the one that I showed you in the echo loop before. Sometimes you can use atenolol that might improve the SAM and the atrial fibrillation altogether. So it's a bit, the approach, at least in my opinion, the approach that I have in atrial fibrillation between cats and dogs is a bit different. So for dogs would always be diltiazem and digoxin, or at least diltiazem to start with and potentially the combination after if diltiazem doesn't work. In cat, it might be different. Perhaps I'll start deltazim. Sometimes I actually use sotalol as well, just because it does have a bit of beta blockade. And sometimes if you have a big enough left atrium, usually means that there is a severe enough underlying cardiac structural disease. So they might have also some VPCs or ventricular arrhythmias on top of it. So sotalol might help everything. But yeah, it's slightly different. I would probably consider deltazim and atenolol to start with in cats, not together, but at least deltazim to start with, and perhaps atenolol after. But yeah, it is it's a bit a different approach compared with dogs. Yeah.
And Emma asked a question again, just around that actually. Are there any published studies for cats in that area for AF?
Not aware of
Extrapolate
it.
all from
No,
the
there is a
canine.
lot of literature in atrial fibrillation in dogs, especially in the last 3 or 4 years. There are some really good overall review of atrial fibrillation, including the pathogenesis and treatment and everything, but not, as far as I'm aware, not much in cats, I'm afraid. No. It's not an extremely common findings, to be fair.
Yeah. Interesting one as well. ACP in dogs for heart failure for X-rays. Are you concerned about dropping blood pressure and the sort of risks of that with ACP?
Yeah, there is always that risk, and this is definitely not something that we want to do. But again, is what you're using for. If you're just using for an X-ray, perhaps together with butorphanol and alfaxalone, you might end up using a very low dose anyway, and not enough to cause a drastic blood pressure, a drop in blood pressure.
Yeah. Okay, and then probably the last one, just frusemide rescue. Do you do it every hour at the beginning?
So in the acute setting of heart failure, yes. So once we've done the first bolus, technically, again, I'm afraid there is no a consensus. There is no a template that we can follow that it works for every patient. What I usually do is I usually start with the first bolus at a higher dose, so 2 mg per kilo, 4 mg per kilo, depending on the severity, and then we have someone assessing the patient, and based on the response of the on the diuretics, we decide to go every half an hour, every 2 hours, every 4 hours. But we usually do 1 mg per kilo every hour to start with after the bolus, and then we assess the response. If the respiratory rate drops from 60 to 30 in 2 hours, then there is no point in doing the hour after. Perhaps we start increasing the gap every 2 hours. And if it's under control, then we might do every 4 hours. In some cases, instead, we have cases that have furosemide every hour for 6-7 hours in a row. So yeah, it will depend on the severity of the disease and the presentation. Bear in mind also that the more chronic the heart failure is, so meaning that if the client say, oh, actually, I noticed it was not breathing very well in the past 3 days, that's going to take a long time to drain the lungs. Whereas if they say, oh, he was doing absolutely fine, and then he start breathing very fast, very quickly, that might be a bit easier to drain. So the furosemide is going to be, you're going to need less furosemide in this case. So it's very variable depending on the presentation.
Yeah, that's fantastic. Thank you. Thank you, Fabio. It's
really nice
really good. Yeah, no, that's really good questions. So just to reiterate, Fabio is part of the cardiology team along with Ilaria Spalla and Valentina Palermo here at VET.CT. So they work really, really closely together and with all the other disciplines as well. Really valuable part of the clinical support services here. I think there might be one last slide at the end here, Fabio. Maybe if you can just move it on.
No, I don't think so.
No, that's fine. That's fine. So there are other talks coming up. I think the next one is in a couple of weeks' time. So do look out for that. That'll be across social media as well and in our advertising. But thank you, Fabio, for your time and the
Thank
great
you. Hope it
questions.
was useful. And yeah, get in touch if you have any question or have any interesting cases. We'll be very happy to help with.
Perfect. And thank you, everybody, for your time tonight, or if you're watching this back as well. It's been great to have you on board. Thank you.
Thank you very much.
Bye-bye.